Hello, and welcome to the Case-Based Educational Curriculum. I'm Dr. Rebecca Walker from Stanford University School of Medicine, and today we'll be discussing a case of abdominal pain that presents to the emergency department. Abdominal pain is actually the most frequent reason for presenting to the emergency department in Cambodia, and subsequently the most frequent reason for being admitted to the hospital after presenting to the emergency department. So our patient is a 38-year-old male who comes in complaining of epigastric pain and vomiting. This pain he describes as worse with eating or drinking. So we have to ask ourselves whether this could be an emergency. And since the pain was severe enough for this patient to come to the emergency department, we recognize that yes, it could be. And so we move to figure out what we should do next. And given that it's a potential emergency, we decide to act quickly and move him to a bed. So here's our patient. A 38-year-old male who's speaking in full sentences and describing the abdominal pain. So what should we do next? We work with our initial assessment in the same manner as all emergency department patients and evaluating the ABCs, airway, breathing, and circulation. So we note that his airway is open and clear, his mucous membranes are dry, but he's speaking without difficulty. He shows good air movement and his lungs are clear bilaterally. In checking his circulation, we note a fast pulse and a brisk capillary refill. These are our providers checking capillary refill on his fingers and listening to his lungs. Next, we check vital signs and find that he is afebrile. He's tachycardic, which we first noted on physical exam. His blood pressure is stable. His respiratory rate and oxygen saturation are within normal limits. So what should we do next? Our initial actions should address the tachycardia and the history of vomiting, which are concerning for volume depletion. We know from physical exam that his mucous membranes are dry and he appears dehydrated. So we first want to place an IV and give IV fluids. We want to put the patient on a monitor so that we can be aware of any changes in his condition. Our initial actions, we have the nurse place an IV. We put the patient on a heart rate and blood pressure monitor, and we start 1 liter of normal saline bolus. So we take a history and note that the pain started 2 days ago and is worse with eating or drinking. Initially, the pain was mild in his epigastrium, but is now severe and radiating to the back. He normally drinks alcohol and drank a lot in celebration a few nights ago. He has not eaten anything today because of the vomiting and pain. He denies constipation or hematemesis, and he also denies any surgical history or past medical problems. We then move to a detailed physical exam, confirming his volume status as low, lacking peripheral edema, and a detailed exam of his abdomen, given his chief complaint of abdominal pain. It's important to be very thorough in examining 5 key areas of the abdomen. As my colleagues here demonstrate, we must palpate the right lower quadrant, the right upper quadrant, the epigastrium, and the left upper quadrant and left lower quadrant. Here we demonstrate where all of those 5 areas are located: the epigastrium, the right upper and left upper quadrants, the right lower and left lower quadrants. Each area should be examined for tenderness, masses, and guarding. So in review for our patient, he has shown us that he has dry mucous membranes and tachycardia concerning for dehydration. His abdomen is tender in the epigastrium, it's non-distended, and he is non-tender in the 4 quadrants of the abdomen. His lungs are clear bilaterally. So what diagnosis do we think the patient has at this point? There's a few that should come to mind immediately as very dangerous causes for epigastric pain: pancreatitis, cholecystitis, esophageal injury or peptic ulcer, small bowel obstruction, and even a myocardial infarction may all be causes of epigastric pain. So what diagnosis do we think this patient has? Well, his pain was radiating to the back. He's had pain with eating and drinking for 2 days. He's had vomiting but no hematemesis. He denies constipation, and he has a history of alcohol abuse. He's a non-smoker with no past medical or no surgical history, and his physical exam is as described. As you can see, epigastric pain can result in quite a few different emergencies, so it's your job as the provider to distinguish which diagnoses the patient is most likely to have based on their history and physical exam. Starting from the top, Our patient has epigastric pain, nausea and vomiting, and he was tender in the epigastrium. We see that those symptoms are associated with pancreatitis, cholecystitis, esophageal injury or peptic ulcer disease, and a small bowel obstruction. Patients with myocardial infarction as a cause for epigastric pain are much less likely to be tender in the epigastrium. Our patient also admits to a history of alcohol use, which is a risk factor for both pancreatitis and esophageal injury or peptic ulcer disease. His pain is worse with eating, which can be seen in pancreatitis and gallbladder disease. It's important to note that our patient, however, was not tender in the right upper quadrant, which would increase our suspicion for a diagnosis of cholecystitis. The pain did radiate to his back, and he denied a history of abdominal surgeries, which makes small bowel obstruction less likely. Hematemesis would make us concerned about an esophageal injury or peptic ulcers. He denies smoking or other cardiac risk factors, and this patient is only 38 years old, so we see myocardial infarction as a less likely cause for this particular patient's pain. In fact, from our history and physical, it seems that this patient most likely has pancreatitis as a cause for his symptoms. It's important to note that the two most common causes of pancreatitis are alcohol use and gallbladder disease. However, there are less common causes such as high triglycerides and certain medications as well. So as this chart demonstrates, epigastric pain can result in quite a few different emergencies. So it's important to distinguish them initially by history and physical, and subsequently by lab tests and imaging that we'll discuss in a minute. So our patient has epigastric pain, nausea and vomiting, a history of alcohol abuse. He was tender in the epigastrium, however, he was not tender in the right upper quadrant. His pain did radiate to the back, and he denies smoking or any cardiac risk factors. So, for starters, our patient most fits the picture of pancreatitis, as we note that he lacks right upper quadrant pain, and he does have a history of alcohol abuse. It's important to note that the two most common causes of pancreatitis are alcohol use and gallbladder disease. However, there are other less common causes such as high triglycerides and certain medications as well. So after knowing more details about all of these disease processes, let's go back to our patient. We're now worried about pancreatitis. So where is the pancreas anyway? Here you can see where the pancreas is, which explains why it is concerning if the patient has tenderness in other areas. Tenderness in other quadrants of the abdomen should make us concerned for other disease processes instead of or in addition to pancreatitis. So now that we've completed our initial assessment, our initial actions, performed a history and physical exam, we may still want to consider additional lab tests or imaging. Do you think there's any indication in this patient for x-rays, an ultrasound, blood test, or an EKG? Well, let's talk a minute about what these tests would tell us about our patient. The first thing to think about when ordering tests is to decide how the study would confirm or differentiate a particular disease process. Abdominal x-rays are useful to look for air fluid levels or dilated bowel, which would suggest a small bowel obstruction. Chest x-rays are useful to look for pneumomediastinum or free air, which would be suggestive of an esophageal injury or peptic ulcer perforation. Ultrasounds are indicated in patients with pancreatitis and right upper quadrant pain to evaluate for the infection of the gallbladder or an obstructing stone resulting in choledocholithiasis. The illustration below shows a gallstone blocking a duct which causes the pancreas to be inflamed. In this case, the stone must be removed surgically, and all of these conditions are actually surgical emergencies, and if they are present, patients should be transferred to a CP3 hospital where a surgeon is immediately available. Blood tests can also be useful, and considering the diagnoses that we've decided are important to consider, let's talk about a few specifically. Lipase is usually high in pancreatitis, but may initially be normal and may be normal in cases of chronic pancreatitis. Troponin will eventually become elevated in a myocardial infarction, but it also may be negative initially. Glucose is often high in pancreatitis and is a sign of severe pancreatitis. Leukocytosis can also be a sign of pancreatitis or infection or other process. An EKG is particularly important in older patients, patients with a history of coronary artery disease or risk factors for coronary artery disease. Elevated ST segments and T-wave changes suggest that a cardiac event may be the cause of epigastric pain and vomiting. So in summary, lipase, glucose, and white blood cell count are often high in pancreatitis, and for lab tests and imaging in pancreatitis, the X-rays, ultrasounds, and an EKG are useful when the diagnosis is unclear, and blood tests can be useful to confirm the diagnosis of suspected pancreatitis. So let's talk for a minute about management of the patient with pancreatitis. We already talked about IV hydration and bowel rest. We also want to offer the patient pain or nausea medications. And the patient should actually stay in the hospital for all of those things to happen. So what is bowel rest? It simply means having the patient not eat or drink until the inflammation around the pancreas is improved and they're able to slowly increase their tolerance of a diet, progressing from clear liquids to starting a bland diet for several days. This is the IV fluids that we're giving our patient, and most patients with pancreatitis need 1 to 2 liters as a bolus for initial volume resuscitation when they arrive. Due to their vomiting and decreased intake of fluids and food, they'll also need to be continued on replacement fluids and electrolytes until they're able to tolerate liquids by mouth without vomiting. Medications for pain include paracetamol, which can be given IV if the patient is still vomiting, and metoclopramide for nausea, 10 milligrams IV. So reviewing what we've done with our patient so far, his history was epigastric pain, alcohol use, and pain that's worse with eating and drinking. His vital signs showed us tachycardia, afebrile. We started an IV and gave him 2 liters of normal saline as a bolus. We decided not to order an ultrasound on this patient given his classic presentation of alcoholic pancreatitis and lack of right upper quadrant pain that would be concerning for gallbladder disease. His lipase was elevated, his white blood cell count and glucose were elevated, which is common in pancreatitis. And for therapy, we've given him IV fluids, pain medicine, and bowel rest. So his hospital course, we have replaced the volume status with electrolytes. We're monitoring his glucose when he's a patient in the hospital, and we want to re-examine him for signs of any complications. And signs of complications would include a deteriorating condition, whether that is worsening pain or concerning vital signs, and also a failure to improve. So if the patient is failing to improve, we want to think about complications that may be arising in our patient. So what complications exactly should we consider? Well, necrosis can be caused by secondary inflammation and tissue destruction around the pancreas. This often requires a prolonged hospital stay and sometimes surgery. An abscess can accumulate, which is an infection that would require surgical draining as well. A pseudocyst is a fluid collection around the pancreas that may require surgical draining and can cause intense pain around the pancreas. All of these can be diagnosed by a CT scan. And higher risk patients are patients who are over 55 years old, have hyperglycemia, and a high leukocytosis. So these patients you should particularly watch for development of these complications that would require surgical management. But our patient, however, did not develop any of these complications. He had nothing by mouth for the first 2 days. A clear diet was started on day 3. He stayed in the hospital for a total of 4 days, and he was back to work on day 5 doing well. So what can we do if you're unsure whether your patient has pancreatitis? Remember, we consider using imaging, blood test, and an EKG to help you. If they have very mild symptoms, you can observe them in the hospital or have them return in 12 hours for a recheck. So does alcoholic pancreatitis require surgical treatment? Usually no. In the absence of complications, alcoholic pancreatitis does not require surgery. And is there any treatment that I should start before admitting my patient to the hospital? For pancreatitis, you want to give IV fluids, give medication for pain and nausea, and ask the patient to stop eating and drinking. One pitfall to discuss with pancreatitis is not considering gallstone pancreatitis in a patient with right upper quadrant pain. Surgery is the treatment for gallstone pancreatitis to avoid bile duct damage and infection. Another common mistake is to not consider complications when the patient's condition worsens. Necrosis, abscess, and pseudocyst must be diagnosed with imaging and may need surgical management. So if the patient's condition is worsening, consider transferring that patient to a hospital with a CT scan or a surgeon. Another mistake is not allowing the bowel to rest by stopping the patient's diet. Pancreatitis will be made worse by continuing to eat or drink. So it's actually really important to keep those patients from eating or drinking until they're able to tolerate small amounts of clear liquid without pain or vomiting. A few myths to consider, especially with alcoholic pancreatitis, is that only older patients have been drinking alcohol long enough to have complications from it. In actuality, alcoholic pancreatitis is common in young adults, and decreasing alcohol use will prevent recurrences. Another common myth is that a patient with pancreatitis should be able to eat the next day, and many patients with pancreatitis must actually be on IV hydration and bowel rest for 3 to 5 days before they improve. In summary, fluid resuscitation and bowel rest can save lives in patients with pancreatitis. All patients with pancreatitis should be admitted for IV fluids and observed for signs of a more complicated diagnosis, which would require surgery, including choledocholithiasis, abscess, pseudocyst, or necrosis. If the patient's condition deteriorates, they fail to improve, or the diagnosis is unclear, they should have imaging of their abdomen, a CT or ultrasound. Common lab abnormalities in pancreatitis include a high lipase, leukocytosis, and hyperglycemia. Supportive care should be given until the patient can tolerate liquids by mouth. Thank you for your attention, and this concludes the case-based educational curriculum on alcoholic pancreatitis.